So it is truly a privilege to be speaking here today at this opening session. And I really am humbled to be speaking after and just before such amazing scholars and lecturers. I'll try to do my best in the coming 50 minutes or so to cover a lot of ground. And what I will try to add to the conversation today is matters that are associated with the practical impact of using health data and AI to actually drive healthcare transformation. And with no further ado, let's begin. So as we are trying to think about how we're implementing changes in healthcare, the first thing I think that we need to ask is, why do we need to fix something that isn't broken? So the first notion that I think that some of you that are involved in healthcare for a while know, and others that come from the technological domain may know less, is that we universally in every healthcare system have a serious problem. We do not provide appropriate care. 30% of the care that we provide, by many estimates, is futile, no value added. Up to 45% of the necessary interventions that are appropriate and helpful are being missed on our everyday care. And according to some estimates, latest one in Journal of Patient Safety from a few years ago, but several others have been claiming that medical errors, not negligence, not something that was done in a wrong way, but medical errors are the third cause of death. And these are honest errors done by physicians and nurses and care providers that work in a system that do not take into account the human flaws and the inability to be accurate. Pilots make mistakes too, but not every time a pilot makes a mistake, it turns into a disaster. In healthcare, we work in a strained system with very little assurance that in too many instances allows mistakes turn into serious detrimental effects. So we deserve more, much, much more. So imagine for a second that you had a gift, that you could look into the future, that you could look at someone and know that something bad is going to happen to them, and that there's something you can do in order to alter their care pathway, which is actually what we're trying to do. In healthcare, the ability to predict the future means a change of paradigm. Instead of basically the patient coming in to the physician with their ailments and complaints, it's the physician that actually calls the patients in the morning and says, good morning. Good morning, the patient will reply. How are you? I'm well. How are you? I'm just fine. The reason I'm calling you is because our data suggests that in the coming week, you will likely suffer from a heart attack, a myocardial infarction. The likelihood is exceedingly high. So I would like to ask you to come to the clinic, and so we can fix some basic aspects and you can go around with your day as usual. So I know this sounds to some of you like science fiction, but it is not too far from the practicality of care. And I will give you a few examples of how this is being materialized. Let's take one example. I know I can only estimate that many of you have family or relatives that have suffered or are suffering from end-stage renal disease, from the need of dialysis or renal transplantation. This is an exceedingly debilitating condition that is very troubling for the patient as well as their family and caregivers. Now, when a patient has the signs of symptoms of renal failure, it is in many instances too late to make a true difference in their outcomes. If we want to make a difference in the outcome of renal failure, we really need to come very early on when the patient looks well and feels well, but there's delicate signs and hints within his information that tell us that he's on his way downwards. And there's a lot we can do at that point. And then at that point, very early on, with pretty simple, cheap, and non-painful interventions, we can change the pathway of the patient. But in order to do that, we need to know who are the patients at risk of developing CKD in 5 years. And for this, we need data sets that go back 5, 10 years, so we can do a retrospective look and find a prospective cohort to look at and identify those patients who will deteriorate and pick them up from the crowd. Now, many of the examples I'm going to give you today come from the health system I work in. And I am a physician by training, a public health physician that works in a health system in Israel called Clalit. And just as an intro to the Israeli healthcare system, Israel is about 9 million population with mandatory enrollment for all in national healthcare insurance. The provision of care is done by 4 sick funds or health systems that serve as payers and providers and are non-for-profit. Everybody is covered by one of these 4, and they do not pay them directly. The enrollment is government funded. There's very little copayment for appropriate care, and you don't pay for GP visits, for emergency inpatient care, and a lot of other services. So this is the basics. And Clalit is the largest one of these 4 providing organizations that provides care to over half of the Israeli population in 1,500 clinics and hospitals that span for 1/3 of the acute hospital beds in the country. And because we care for the patients usually from cradle to grave, there's a lot of focus, economic as well as clinical focus on prevention, because the patients stay with us from cradle to old age. So there's an incentive to be preventive in our approach and innovative in the way we provide care. And so the vision of a system that tries to look at the long term and witnesses the challenges of the inability to provide proper care, as I've shown you before, is to change the way the system works. And currently our system, and I'm sure some of you can relate to some of these, works in a very specific way. We work in silos, okay? The hospitals work in their own silo, and the general practitioners that work in the community are completely disparate and do not talk enough. There's not enough crosstalk. We provide equal care when we want to be much more equitable and much more change the amount of care and the intensity of care according to the needs of the patient and not go in an equal way. We are very therapeutic and reactive when we want to be much more preventive and proactive. We are still exceedingly paternalistic and system-centered instead of being engaging and patient-centered. And finally, we are many instances flying blind when we want to be value-driven. And the key to change all of these and to make this transformation basically is data. And so at Clalit, we have 25 years of electronic health record, payer and provider, economic, clinical, and every type of data that you can imagine on 4.7 million patients going on for 25 years. That's a lot of data to work with and to be able to do things. And indeed, I think that this trove of data allows us to do much of the things that I will present as I show you on. And because the data is integrated, inpatient and outpatient, and payer and provider, and diagnostics, and the drugs, and the images, and the omics data, and all of this is in a centralized data warehouse that is ID tagged and geocoded, you can create those predictive models that we've talked about. So looking back 5 years and finding out who are the patients at risk is quite easy, basically. And we have been performing this type of predictive proactive care for preventing renal failure and have been reducing dramatically in the last 10 years the likelihood of patients to deteriorate to end-stage renal disease. This type of approach can be used in many other clinical domains. And so you can think about this approach of population health. Let's take, for example, the influenza vaccines. When we come in every winter to provide influenza vaccines to our patients, in the past, the way we provided them was in alphabetical order. We called the patients, every clinic had their list of patients in an alphabetical order and called them in and tell them, you know, you really should come in and take your influenza shot, which is fair enough. But what we have tried to do in order to change that was to create, yet again, a predictive model that looks on all of our patients and try to rank them according to their annual risk of developing winter morbidity, pneumonia, and other complications of classical complications of influenza. So by creating such a model and ranking our patients, note, go back to the previous talk that we've just heard, we are not changing the standard of care. In this case, we are only allocating the care, the ranking of our proactive approach according to the personal risk. And by calling those patients who are highest in their risk first, we are able to use scarce resources in a way that optimizes the overall benefit from this effort. In this case, the outreach for annual vaccination. By the way, it is very interesting to note that the most influential factor in this model, trying to look at who is at risk for severe winter morbidity and to influenza and its complications, is classically the same people who had this type of complications last winter. This is not only because they are more susceptible in nature as an individual, but also because if they've had it once, it proves, and we show this in an empirical study, that they are in the center of a network of people that transmit influenza from patient to patient. And so if you think about it, a younger kindergarten teacher is at a higher risk of annual complications than an old hermit that lives on his own. And so the fact that someone was sick last year is a very, very good predictor of what is going to happen next year. And that proves to be the case in many instances. Things tend to happen to the same people again and again for various reasons, not only individual susceptibility. Now, this whole concept of providing care according to individual risk and predictive proactive approaches are really dependent on your ability to do risk stratification. Basically taking your population, creating a score for every relevant individual, and then ranking your population according to that risk. Now, one would tend to think that in many instances, higher is more appropriate and higher is more urgent, and it becomes very simple to do the prioritization or the care allocation. But that's not always the case. And let's try to understand how it actually works in real life and what are some of the complexities of providing predictive proactive care. In many instances, it is the higher risk scores that have risk high enough to justify intervention in terms, for instance, of risk and harm ratios. However, in many instances, when we look at risk for specific complications, it is in many instances the case that the highest risk individuals, those at the very top of the risk pyramid, are actually those that are beyond help, where what we call impactability, your capacity to affect change using an intervention and to avert the patient from harm's way, is actually lowest among those people with the highest risk of complications. So in some instances, when you try to allocate the scarce resources you have for predictive proactive care, you do not go for the top of the pyramid. You actually try to model, to assess, and then to test the impactability. It could be an intervention that is, a drug or a surgery, but in many instances, it also is a more generalized intervention, as I'll show you in a second. And in those cases, it is this middle group. Let's take one example, for instance. The example that I'm going to give you now is that of multi-morbid patients. In many health systems, one of the holy grails of trying to address economic needs is the attempt to identify the patients at the highest risk of hospitalization or deterioration and providing them with early care. But in many instances, these interventions fail to be shown to be cost effective because of this conundrum of the fact that those people who are at the highest risk do not benefit from the intervention. We were able to create a predictive model and identify those patients at the highest risk of multi-morbidity driven personal general deterioration and need of admissions, of hospital admissions. But then we have created a set of rules that identify those that are not likely to benefit because they are overly sick. And for this strata that we see here, we provided care that was driven by a nurse and a physician as a pair and a team that created a care coordination plan for those patients and adjusted the recommendations for each one of their different morbidities so they can fit each other. Because in many instances, multi-morbid patients get very contradicting recommendations from physicians because the different diseases negate each other. Just as an example, one of the most classic combination is patients with chronic heart failure, chronic renal failure, and diabetes. This triad of 3 diseases sounds pretty trivial, but as a matter of fact, many of the drugs that are recommended for one of these illnesses contradicts the other one. And it comes to a point in which these patients don't even have appropriate dietary recommendations. Because let's see for a second, those with chronic heart failure cannot have salt and have to limit the amount of water they ingest. Those people with chronic renal failure must make sure that they have enough water intake and have to consider careful dietary restriction of protein. People with diabetes cannot have sugar and need to maintain their fat. So I must tell you, those people have nothing to eat. So without a proper guidance, they are usually lost. So we gave those patients this very dedicated treatment with a nurse and a physician. And what we saw, that we could indeed identify those patients at high risk. And what we see here is the basically the pre-intervention average number of inpatient days for these 2 groups. And this is what happened post-intervention. Those in the control group did manifest the prediction that we've had. They have dramatically increased the number of inpatient days from year to year. But those people in the intervention group actually had a lower number, and this was actually cost saving and saved hundreds of dollars in patient care by the proper selection and intervention of this group. This is true for many, many trials, and nowadays finding this right group for intervention is critical. So what we've seen thus far is really a bird's eye view of a change of paradigm from a patient level reactive therapeutics, which is what we used to be doing, to population health, predictive, proactive, and preventive approaches. And we are doing this today at Clalit for millions of patients on a daily basis, providing, finding those patients at the highest risk, doing outreach through their general practitioners to those patients and changing their care in order to reduce future risks of their care. Now, sometimes this prediction is trivial, and sometimes it's non-trivial. Sometimes, for instance, when you used neural nets and other opaque models, it is difficult to understand what's happening. And let's take one example. At some point, we wanted to predict osteoporotic fracture. Osteoporosis is a disease of the bone where it becomes brittle and tends to break more often, mainly manifested in older females. And we wanted to predict who are the patients at the highest risk of this osteoporotic fractures. And what we found from the modeling we've done was that the most well-associated component to this was eye disease. So I went back to, to the classic books, and I could find no association between eye illness and osteoporosis. So, we thought we had it wrong, or that the model got it wrong, was that this was spurious. But after a while, it came to us. It's not that eye diseases are associated with osteoporosis. Eye diseases are associated with falling, and falling induces fractures of these brittle bones. That's why this was such a strong predictor. So in many instances, it's difficult to create white boxes and to have the explainable AI and explain to ourselves and to the physicians what are the sources of some of the associations we find. But we find it, and I'll talk about it later on, critical to try and have explainable AI as to the extent possible in many of these instances. Now, as we advance some of these models, we can also use not just the classical phenomic data, but more and more unstructured data, such as in this case, images. So in one of our projects, we have taken chest CTs. We identified through machine learning the specific attributes of hidden fractures as well as low density of the bones from normal CTs that were done for other reasons whatsoever. And we integrated this data into our models in order to better predict these fractures. And we see this more and more. We now have an intervention process on a large scale that uses, for instance, calcium scores from chest CTs that were done for other reasons as part of our predictive model of cardiovascular interventions in our daily practice provided for these patients. So in the past, we used to do these things with the traditional biomarkers, the demographics, the vital signs, the monitoring of medical grade sensors, the lab tests, the drugs that the patient receives, and classic tests, molecular testings, and even omics. But we are now moving to an era where we will be using other types of biomarkers driven through AI and machine learning from unstructured sources. And there's a lot of implementation now looking at some of these things you see here. We can, and we are working with a startup that takes a short recording of the voice of the patients and identifies, for instance, signs of atrial fibrillation, because the heartbeats actually manifest themselves on the voice. So you can actually identify heart rhythm from a recording of a patient's voice. I've shown you a little bit about imaging. Everybody, I think, knows some of the seminal work done on retinal scans and the ability to look into cardiovascular risk factors from that. And we can go on and on, but I think that the behavioral or the behavioral biometrics that we will be collecting, and we saw the example of that cute seal that was presented in the previous presentation as an example, they are becoming more and more relevant to our daily work. And we do see more and more implementation of this in our practice. And all of these and more will be providing us, and some of them are already providing us with inputs for our predictive models. So all of this is all good and well, but what happens to the physician that stands at the end of this incoming chain of data points and inferences? How would they make sense of all of this deluge of data that falls into their electronic medical record? Some of this is health system driven, some of this is patient measurement driven, some of this comes from patient reported outcomes and preferences. How does that all mix up together and allows the general practitioners to provide care in what usually is a 15-minute slot to provide the patient with all of the care relevant, proactive and reactive to what they came with? This is a serious task. And in order to tackle it, what we have done is really created an integrated system. We call it CPI, proactive preventive interventions at Clalit. And this system that was launched this year, work of several different parts of the Clalit system, the community health division and the digital health division, and a group of very talented physicians working here at the Clalit Research Institute, led by Dr. Noah Dagan, which I'll mention in a second, one of the most prominent physician scientists working on these projects, has been able to do a very smart integration. First of all, it takes the 2,000 or 1,500 patients that the physician cares for and integrates all the data on them to tell which one of them is most urgent for intervention today. And so you have this specification. And then when we hit that specific patient at high risk, you see what are the predictive models saying about their various risks, what are the suggested interventions for each one of those and why, in an explainable format. And then with the batch format, you can actually put a V checkmark on all of the relevant interventions that you want to introduce. And with the click of a button, all of these turn into specific recommendations, prescriptions, and referrals, and go into practice. And all of this is being done And we are now paying our physicians for 2 hours a week to do work with this system and provide the entire patient roster with predictive, proactive care on a daily basis. So I think this is one avenue by which predictive, proactive care can flow into the daily practice. And the other way to use these types of predictions is to take them into the patients and empower the patients to make the right decisions based on this data. I would like to take the opportunity and show you a quick video that presents how this is actually being done. Let's see if we can make it happen. I hope this will work. Okay, and
yes, we can see it. Is there sound?
Oh, you do not hear the sound. Okay, I didn't know that you cannot hear the sound. Okay, so I will Philip, I will continue without. I will present this verbatim. So the other option in order to provide this type of care is direct to patient. And how does that work direct to patient? By taking, creating an app that provides the patient with a personal assessment of their individual risks. And basically, we do this based on all of the data that's available in the patient's record and inferences coming from the entire patient population and allowing them to assess of a certain disease, for instance, in this case, stroke, but also what would happen if they change every one of the specific manageable settings in their health status. For instance, what happens if they reduce their systolic blood pressure by 10 points? What happens if they stop smoking and move from smoker to non-smoker? For them specifically, based on the data of every other single patient at Clalit, what would be the impact on them on reducing the risk, as you can see here in these slides, from 4% to 2%. And once they choose their goals, there's a whole set of interventions that's provided to them that they can choose and connect with the system. So we saw how this works direct to physician. We saw how this works direct to patient. But I want to open another interesting angle into this concept of predictive proactive care. And in this case, it has to do with health economics. Now, health economics of predictive prevention works in an interesting way. The highest, let's put it this way, effective treatment and care and prevention for those at the highest risk is in many instances cost saving to the payer. So there's a high likelihood that the payer would actually go ahead and finance and promote this type of care as part of what they're doing, okay? So we will see them manifested as Clalit, for instance, has done with all of what I've shown you before. The care for the lowest risk patients and preventive care for those patients is in many instances waste and should not be done. The levels that come between, some of them are indeed cost effective. They have a good ratio of expenses to benefit, but overall it is a costly intervention. But there's a very interesting sweet spot just here that says, you know what? For the payer themselves, this intervention, this prevention may not be cost saving. But for the entire economy, if you take the benefits for the payer and the benefits for the national insurance and the benefits for the government payments and the overall view of what the impact is on the economy, it is cost saving, not only cost effective. The problem is that the provider of the care, the payer, does not see and do not internalize all of these benefits and all of this cost saving. What can be done in these instances to increase the amount of predictive proactive care that is provided is an approach that that is known as social impact bonds or social impact that actually allows in a system in which all of the institutions that benefit from the prevention of this illness actually collect their benefits and their savings and pay together to the provider of care that creates this benefit and creates this prevention in practice. This is done, one of the ways to do this is what is called a social impact bond, in which you can, investors can actually purchase this and invest in this preventive approach and benefit if it becomes actually effective. And it proves it on financial terms to be in many instances more valuable than other investment opportunities. And also it is an opportunity to do well by doing good. We have created such a social impact bond on preventing diabetes. We provide predictive proactive treatment for diabetic patients in Israel. We actually have been in a meeting today where we looked at some of the benefits that were shown, and we've shown a dramatic over 20% reduction in the transition from pre-diabetes to diabetes. And we will actually pay back money to all of those systems that have provided the care in this process. So I think that we've covered the issue of proactive care. And I want to say that, you know, we are living in an era where we have many opportunities to transform care through data. And proactive preventive care is just one approach. There are others that we will obviously not have time to cover today, but we need to take them into account. Through these types of interventions, we are trying to improve our test interpretation accuracy and to have AI systems sift through our pathological images or radiological images and find out things that the eyes of the physicians would usually miss, or provide a second read that increases the safety of these test interpretations. We are using various types of data in order to try and reduce the waste in our system, to find interventions that are not providing the outcomes we expect and causing futile interventions. And therefore, we are trying to put them away from our investment approach. We are trying to provide precise care by selecting the right treatment according to the personal expected impact. And I'll show you an example in a second, to safeguard from error and to increase the patient self-care and decision support. Let's take a look, for instance, at one example of precise treatment. When we want to provide treatment, for instance, on anticoagulation, or in many other instances of providing treatment, we are in a serious dilemma. It's a balancing act. Too much is dangerous. Too little is risky. And we as physicians and nurses, we need to select the right amount of care to provide. And what we always know that the right sweet spot for every patient is personal. However, the data that we can base our decisions on is an average one that is published in the journals. The problem is none of us is average. And none of us wants to receive average treatment in order to find their own point. And one of the ways we're using more and more is the approach of digital twins, in which we are trying to identify in the entire data set patients that resemble, to the extent possible, the patient in front of us, and guide our treatment so we can provide the best treatment for that patient in front of us so they can maximize their benefits. One of the ways we've done this is, for instance, using the SPRINT data, the SPRINT hypertension clinical trial data that was published in the New England Journal of Medicine. And we got this data from that clinical trial through our participation. And again, Noah Dagan was the PI on this one. And we got the data from the New England. And then what we tried to do is the following. We took every individual within the clinical data set, and we created outcome-specific predictive model for every one of the outcomes that we are interested in. Let's take acute myocardial infarction, heart attacks. We looked at a single patient, this 78-year-old female with a specific height and weight and smoking status. And we want to ask, should we provide this patient with intensive hypertension treatment? We can model the risk of that patient for acute MI without treatment through this data of the clinical trial. And we can model the risk with treatment. And the difference between these two is what we expect to be the benefit of that specific patient with those specific attributes from the intensive treatment. From this, we can calculate what is called an individual number needed to treat. So for patients exactly like her, we need to treat 384 such patients exactly like her to prevent one case of acute MI with intensive treatment. We can do this for multiple different effects and adverse effects of this drug. For instance, taking intensive treatment would reduce MIs, but increase the number of acute renal failures, for instance. And you can find for every single patient whether the harms outweigh the benefit or the other way around. This is a truly personalized balance. And then looking at your population, you can find some people where the net is benefit and others where the net is harmful. And you can then classify your treatment for each and every single one according to their personalized likelihood to benefit or not. So using the sprint data, we've shown that actually from the entire population that they have recommended intensive treatment to, there's a good proportion, those marked in red, that are better not to treat because their overall outcomes are worse off. And when we redid this in Israel, we saw that this was also the case for us, although to a lower percentage of the population, but still there was a very problematic benefit harms ratio for a certain segment of the population. So it is the saying of, one of the most famous physicians that ever lived, Sir William Oster. He said, if it were not for the great variability among individuals, medicine might as well be a science and not an art. But it comes to a point in which we should ask at this era, should medicine truly be an art form, or do we want to inject more science and more precision into the way in which we provide care and select our treatment options? I will give one last answer of using AI, this time not in a clinical setting, but again in the operational setting. And in this case, it is a problem known as no-show. 25% of the patients we invite to our clinics actually do not come in. They just don't show up. And this causes really a very serious problem in terms of running clinics and hospitals. And we know that by trying just to send them SMSs and persuade them not to let us know if they're not coming, it's not useful enough and they're not responding to it. What we have done is we used a whole system of testing different ways of phrases used in the SMS and send them to many people, many different phrases using principles of behavioral economics that might have different types of impact, going for emotional messages, going for social norm, explaining to them that they will harm other patients if they take their place, etc., to see what works for different people. And by collecting all this data and putting it into an AI model, we could actually create a personalized machine that sends just the right message to the right patient at the right time. And by doing this, we dramatically increased the effectiveness of these messaging, and we were able to reduce 30% of the no-shows just by adapting the right messages to the right patients at the right time. So this again shows different ways by which you can use AI and predictives in the usual provision of care. I would like to take a few minutes now to give you a brief overview on how all of this actually came to play when we talk about the COVID-19. So you all know when an epidemic comes in, actually whenever a new variant comes in, we're all in a midst of war. We do not know not only where we're going, but we actually don't know where we're at. And so I will show you a few examples very briefly on how we use data in order to provide care during such an event and how this came to play in Israel's response to COVID-19. So I would go very quickly on 5 challenges that we've had in moving temporarily from the February 2020 approximately until mid-2021. And I'll show you different challenges and how we tackled them. The first one was trying to create modeling with no data. The second one was trying to do work with disarrayed data. The third one is to use heavily biased data in order to provide better care. The fourth one will be using what we call small data instead of big data. And finally, what we did when data was unavailable. So let's briefly take a view of, and I'm sorry, I will be very brief on some of these examples, but I will try to leave time for questions. So the example of no data was very early on in February 2020, when we wanted to create a prediction model of which patients are going to deteriorate to severe conditions once they are infected. The problem was, it was February, we didn't even have a single case. What did we do? We went back to our old influenza. You remember from the beginning of my presentation, the influenza predictive model on severe morbidity. And we looked at the different variables that were relevant there. And actually, you can see that once you run the modeling, you find different types of labs that have been shown to be predictive of deterioration of seasonal flu and winter morbidity, but later on, it was also found to be associated with negative outcomes of COVID-19 as well. So then we took all of these features, created this model, but it created a model for flu, not for COVID. COVID has very different, and we knew that from data that came in from Italy and China at that point, we knew that there was a different proportion of severe cases by age than with flu, much more for the older age groups and less for the younger ones. And so we used a methodology developed by Guy Rothblum and colleagues in which you basically nudge the outcome of your model post-production in order to fit it to a different proportion that you define in advance. And through this work that was a combination of many different institutes working together, we created the COVID-19 mortality predictor. And in hindsight, it was exceedingly effective and useful. First of all, it was precise. With 7% of the population, we could identify 69% of those who deteriorate. So it proved to be quite accurate. And we used this system even as early as March 2020 to call all of those high-risk patients and tell them, stay at home. Do not expose yourself and use online care instead of normal care coming to the clinic. Not only that, some kind of a derivative of this predictive model is now used for us to provide antibody treatment, and more recently, the Pfizer oral treatment for severe illness. And we have a limited amount of these drugs, and we can now allocate them to those at the highest risk based on individual modeling. So this was quite effective use of the data. The second example, disarray data, and for this I'm referring to the second wave that we've experienced, and that was in August 2020. And our biggest problem was, where do we allocate our tests, our PCR testing that was limited? What we've done was create what we called at that time Corona meter, which was a basic predictive model that told us every day about which are the patients that are most likely to be identified as patients in the coming week and where they were. And what we did, we introduced into the EMRs of our physicians an alert that showed whenever a patient came into the clinic and he was part of this high-risk group, and you can see here that among the higher risk groups, the positive predictive value was, sometimes as high as 40% or 20% when we're talking about the highest 1% of the population, which is basically 40,000 people every day. And so when such a patient went into the clinic, the physician was most of you can't read Hebrew, but what it says here, dear physician, please ask this patient about their signs and symptoms of COVID-19 and send them for a test if they have relevant complaints. The third example I want to give you of the working with bias data or with was in a point in which in our third wave, we began vaccinating our population, but at that time, beyond clinical trials, we didn't know how effective vaccination is going to be. And we were one of the earliest countries to vaccinate. You can see here Israel in the most left-hand line, showing that we really provided over 50% of our population with the vaccine as early as January 2020. And very few countries were even close to that at that time. So we couldn't know if the vaccine was effective or not. And we didn't know whether we can open the lockdown or not, because there seems to be another surge. What we actually did was to try and emulate what we call a target trial. We tried to redo an assessment of vaccine effectiveness based on real-world data. And we had many, many biases and confounding effects to take into account. Baseline differences between those vaccinated and those that were not. Characteristics that changed over time among those vaccinated as the eligibility changed over time. Infection rates that were changing. Informative censoring, those of you who know some of those terms and how that works. And what we decided to do was really interesting. We tried to emulate a trial, which means that instead of looking at hindsight and trying to create couplets of vaccinated and unvaccinated individuals and compare the morbidity between them, which is not really kosher because you use post-factum data in defining your pairs by knowing the outcome in advance. What we did was very different. What we did was create a cohort of patients where we coupled at every specific day a vaccinated and unvaccinated individuals, but the matching was done in a way that if we had a 56-year-old ultra-Orthodox male from a certain neighborhood in Tel Aviv with 3 chronic diseases, we coupled him at that day with an uninfected, unvaccinated, ultra-Orthodox 56-year-old male with the same amount of chronic diseases. And we followed them prospectively until a point in which the unvaccinated got vaccinated. Then we decoupled those couples. We created a new match for the newly vaccinated person and continued the follow-up in this way, which really tries to emulate to the extent possible what would happen in a clinical trial. And we had 600,000 vaccinees and 600,000 unvaccinated individuals. And we could show that this was done, by the way, with an amazing team here at the Clalit Research Institute, with the team at Harvard, with Miguel Hernan, Mark Lipsitch, and Ben Rice, that were amazingly instrumental in making this happen. And we could show, indeed, that 94% effectiveness of documented infections was the case. So we can make a decision and tell decision makers, you can open the lockdown, which they did. And indeed, morbidity went sharply down afterwards. So I think this was exceedingly instrumental. Since I don't have much more time, I'd like, with your permission, to look at one last thing, and that is we should never let a good crisis go to waste. A very smart man said that once. So we are utilizing what is happening now in COVID-19 to enhance our ability to provide these types of advanced care and to use AI in different new ways in every way possible. Some people are worried that, machines will replace us all. And soon they will, we will need fewer physicians. And I think this couldn't be further from the truth. It's not replacement, it's augmentation. And what we will see is that AI and data-driven applications allow us basically to augment physicians and to replace the technical repetitive tasks that we don't want to be doing as caregivers. And so we will see how repetitive technical tasks are moved away from us, how we are able to provide, use our time to provide more creative, more empathic work with our patients and take away some of the things that we don't really want to do, because if something can be done better by a machine, it probably should be done by a machine and not by a person who spent so many years trying to train in order to do this. Now, this all sounds all too well, but I will end by just reminding us some of the lessons of the previous presentation, that there are many hindrances in this process. And there's a dark side to this. And many of the things that we see here, lack of evidence of effective outcomes is one challenge. Problems of external validity. You develop the model on one population, and can you then make inferences to a slightly or markedly different population? The problem of overdiagnosis is really, really a very serious one. I will go over it very quickly before moving on. Let's take it for example. Let me show you this problem. We have a sensor with sensitivity of 0.996, specificity of 0.996, and a base rate of 1 per 1,000. So we have, for instance, atrial fibrillation. It happens in 1 in every 1,000 people, and we have a sensor with a sensitivity and specificity of 0.996. The machine says you have AF, you have atrial fibrillation. What is the likelihood that this alert is true? Is it 96%? Is it 90%? Is it 50%? The actual truth is it's 20%. So what we will see is what we call sensoritis, a deluge of alerts that are wrong and that would drive the patients through a lot of unnecessary diagnosis and sometimes treatment, as we've seen here on the left-hand side, that once you start making too many diagnostic tests to patients of their thyroid, you begin to identify illness as cancer. You begin to have surgery on these, but there's very little change in overall mortality and very little benefit. So there's a very high risk of overdoing, overdiagnosis, overtreatment coming in from some of these predictive proactive systems. There's the problem of causation. The next talk will definitely talk more about that. There's a problem of biases. As Kathy O'Neill said once very truly, algorithms are not impartial judges. They're just opinions embedded in code. And so we cannot just trust the algorithms. We really had to doubt them appropriately before moving always, because there's a lot of biases in the data sets and in their usage that come and creep into their utilization. I will stop here, and I will mention that, again, that indeed doctors will not be replaced by algorithms, but health systems that do not use AI will be replaced by those who do. I'll end by thanking my amazing team of researchers and scholars at the Clalit Research Institute, our collaborators with different health systems and academic centers around the world. And I'm giving the floor back for any question. Thank you.
Well, thank you very much indeed, Professor Balicer. It was very good to hear the viewpoint of physicians. So this afternoon is very exciting because we started with with a vision coming from the law viewpoint, then medical viewpoint, and later we will have the AI development viewpoint. So it's very good to see how you are able to proceed. Again, I will ask people to put their question in the chat, and to start with, I would like to start with a comment. In fact, it seems that you are lucky in Israel to have a set of data which can be obtained at the level of your complete population, if I understood correctly, or at least a wide part of it. You mentioned 4.5 million of people over 45 years. That's very impressive. By the way, this is something which we try to have in France, and I guess that the Health Data Hub, for instance, is one of the initiatives here, and also at the hospital levels. In many hospitals, such as ours, we are developing healthcare data lakes to be able to acquire all these data. So I was wondering if you had interoperability issues, although you have all these data. How difficult is it in your situation to be able to really use data coming from different information systems? And is this an issue for you?
So I'm almost embarrassed to say that it is this problem was largely solved quite a few years ago, more than 15 years ago. We now use a single electronic medical record system in the community setting, a single electronic medical record system in all of our hospitals. All of the data comes into a central data warehouse. All of the imaging data is through a PACS system that is centrally saved. We put our omics data into order in the last few years. So, and all of this is being really cross-referenced. So as a system, we are very able to use this data into practical, helpful setting. Now, I urge you all to look at the Lancet Governing Healthcare Futures 2030 report that identified some of the key issues of transforming healthcare systems in order to use data in a safe and create an infrastructure of trust that allows the public to share and use data in the proper way. I think we've done it appropriately here in Israel. This gives us the opportunity to use data for patients' benefit.
Thank you. Yeah, of course, it's a great added value to have this way of working. So, but I think it's in your instance is a very good one for us to help us convince people to help in France and in other countries, but in France, to have a possibility to gather all these data in a similar way and probably useful for the Health Data Hub. So I turn to the chat. There are some comments, of course, very positive about your presentation. A question from Romain, who is asking about what happens with the patients who are at the second and third level of the pyramid and not the first one. Could you comment on this about the multi-morbid patients? I think that the question is, do you imply that they are beyond help? I think you are more implying that, of course, they could be interesting for care, but for the type of action that you have in mind, the added value is perhaps more limited. Could you comment on that?
Yes, you need to coordinate the right care for the right patients. Every patient should receive the type of care that would actually be beneficial to them. If you are trying to provide early prevention, in some cases when the disease or the diseases are too advanced, you will not provide the right care for the right patients, those at the highest risk of deterioration. They should receive a different type of care, which is more fitting for their advanced conditions and their intractability of their chronic conditions. So this type of approach is not appropriate for them and they will not benefit from it. They need different types of care. So when I'm saying that they are beyond help, they are beyond help by the specific combination that we are talking about here, and other types of care, much more intensive in approach, might be more fitting for them. And so for them, this type of approach would be waste.
I had a similar question, by the way, regarding those patients who are at the bottom of your pyramid, because from an economical viewpoint, I was wondering if these people could not be a very interesting target because they are so numerous and because the interventions hopefully are not very costly. So it seems that they should also be taken into account even from this economical viewpoint. Would you agree on that?
Absolutely. The only question is who's going to pay?
Yeah, I agree with your remark about the fact that the payer is not only the one that takes the benefit, and this is an issue. Yeah, I agree.
Yeah, you know, health economics could be sometimes very rough because it's always a zero-sum game. And by allocating funding for something, you're taking away money from something else in many instances. So you really want to derive the most health from your investment. What is unique about the example I've given was that you can actually raise money from outside the healthcare system in order to create a healthcare intervention. And because of the benefits for it for other systems that are non-health related, like productivity at work, so you get money from the national insurance, etc., you get money from the outside and from investors in order to do a health intervention within your system because the overall net benefit for society exists. And there are specific sweet spots like that. And if you find them, you can get more dollars into your healthcare system from additional sources above and beyond what you have been allocated.
Okay, we have a question from Iftera. If could you take the microphone, because I'm not sure I understand the question. Concerning your last question, is there a possibility to evaluate confidence intervals through deep learning algorithms at this time? I don't remember exactly which question. Yeah.
Yes, sorry, because you say that you have a super nice accuracy, but you have like it's 20%. You say 20%. I could not remember like the number, but there is no confidence interval like associated to prediction. Is there any improvement like to make like confidence interval? Because for physician it's essential. I'm working this time like with people who are with physicians who, and it's a very sensitive point, like they really like to have this confidence interval to make like a better like prediction for their patients.
So that, it depends on the method you've been using, but there are ways in which you can add a confidence interval by bootstrapping and by running the model several times and getting various types of results and then finding out where 95% of your answers lie in. So there are ways in order to do that, and people who do this on their daily work actually can create some kind of a statistical, not classic, but statistical boundaries. And I'm sure that you will hear more about it soon in the next talk.
Okay, thank you. We have a question from Pascal Derich, which is a different question, I guess. How to make data infrastructure fit for AI purposes? It's a wide question, I would say.
Yeah, I think, the problem is that AI is such a misused term. It fits anything, basically. From logistic regressions to neural nets to other ways of working with structured and unstructured data. And the infrastructure you need for each one is really differs. So there are many ways to skin a cat, and there's not a specific infrastructure that fits. But generally speaking, the easiest way is to work with structured data, and then anything can do, from classic SQL and R in order to create any type of model. To more advanced assessment development systems. When you want to work with unstructured data, there are different types of infrastructures that you might need, and it depends on the type of whether you want to do image or NLP when you work with text, or different work with bioinformatics when you work with data such as coming from omics, and each one have their own customized platforms that allow you to do it best. Sometimes it works best in cloud settings, sometimes on-prem. It's very difficult to answer in specifically to such a wide angle question.
Yeah. And then we have one last question from Svetlana Artemova, who is asking, how do you deal with the patient consent? Are they aware of the usage of their medical data? And do you include into your analysis data from Internet of Things applications used by patients at home?
Okay, so every time we're trying to do such an assessment, we get an IRB, an Institutional Review Board approval. And according to the Israeli law, when it's de-identified anonymized data, you can use it for research for the benefit of the patients, which we do. But we also make every one of our studies, the outcomes notable to the public. And they are very much overall in favor of this type of use, because this is not theoretical research, academic research. This is actual translational research that impacts their care on a daily basis. They have the right to get their data removed from these analyses, but many of them, very few of these things happen because people want to be included in all of these predictive and other models that would actually be transformative for their care.